All right. Well, good afternoon, everybody. Welcome to our day 3 recap at Klima from the First Responder Center. It's nice to see kind of the same faces each day at the recap. Like you guys are the ones that are hanging out the entire day. But so we've got Scott Robinson with us today, and Frank Leto's hanging on here as well. We hope you had a good day today when we talk about peer support and clinicians. And for anybody that hasn't been on the day end recap, please feel free to write a question in the chat, and we'll talk to Scott, or actually we have Dr. Gist on as well. So a couple of things resonated with me today. Scott, kind of start with you, and one of the things from your sessions that I thought, we're going to talk tomorrow about leadership, but peer support for chief officers, and the challenge with that, especially if you have a peer support team with smaller departments. So I know you touched on it in your session, but I'd love to hear a little bit more about your thoughts on that.
Yeah, like we said in our session, it was, we try to get rid of rank structure in peer support because we're just firefighters helping firefighters. But there is a difference, from going from fighting fires or responding to emergency medical service runs and managing those incidents is a totally different stressor, especially if there's any injuries involved on the fire side or the EMS side for our chief officers. So they need to have a mechanism that we can reach out to them. What we tried doing with us, and we're relatively smaller local compared to some of the other ones that we're talking about, is to train our peers, and then as they grow through the department and become senior, they'll be at the level that we can reach out to. One of the toughest things for me when I first started our program is being told. I had, in 2006, I had 6 years on the job, to be told, hey, listen, I need you to go talk to this captain. He's got an alcohol problem. I'm like, the guy's got over 25 years on the job. He's not going to listen to somebody with 6 years on the job. So we need to create avenues for senior guys and junior guys to be able, and women to work across the board, and I think that it sounds like it's a tough thing to do, but I think it's a pretty easy thing for us to accomplish as peers, because we all want to help each other.
Multitasking here and writing down some questions. So one follow-up question somebody wrote in the chat is, about the topic of compensating peers. So Scott, what about like within and Frank, are your peer support members compensating when they're working? If not, pros and cons, maybe talk about that a little bit.
For us, there's no compensation. We have a peer support program that's run by our local. Our members do it because they want to help each other. Their compensation, if you want to call it compensation, is I use the funding that we receive to educate them. And sometimes that is, being able to send them to a symposium like this, like when you guys had it in Denver, to be able to send members out there, cover the cost of their flight, their hotel, and the conference cost. So I try to do my compensation that way. I don't pay an hourly rate to be able to do this. And I come back on my free time, and so does everybody else in our program, at least.
Right. Frank, are you on? You have anything to add? I lost Frank. So another question, and I'll try to pull it up on my other computer and go over it. And if not, we can certainly send it out. But there was a question about the difference between stress first aid, mental health first aid, and psychological first aid, the different programs out there. And there are certainly differences between those various programs. We actually have a one-page spreadsheet that talks about that. So if while we go into the next discussion, I'll try to pull that up. And if not, we can certainly email that out. the other thing, that's came up in a couple of the sessions today, so whether it's, stress first aid, peer support, and that's certainly, when we need to escalate to a clinician. And I heard numerous times today about, departments that have EAP programs that aren't effective, clinicians that, quote unquote, don't understand us. So I'd love to, and we've got a couple other people on the phone or on the, I see Curt West is on, Dr. Gist is on. So I'll start with you, Scott. Talk about those challenges and how you've seen some departments successfully navigate that.
Yeah, so that's a tough question, and it's a tough question for a new peer, because you wonder, when I started, I had a different view of what I needed to do and be prepared for versus where I am now and my comfort level as a peer. And when I say peer, we're bridges to resources, right? We're not clinicians. We don't treat our firefighter brothers and sisters. We help stabilize them in their moment of crisis, and then provide referral sources to people that can really help them if they need it. So like I was saying in our presentation, the person that's in crisis has the answers of what they need. It's our job to try to cull that information out of them and put it into a cognitive thinking role for them to say, oh yeah, okay, that does make sense. But it was their idea, so that's our goal. So for somebody that's new, and even for somebody like myself, I think you just need to trust your gut. When it comes to like suicide, that's, suicide ideation, you got to trust your gut that if you're not comfortable, then you go into the emergency room. There's just no ifs, ands, or buts about it. Okay. And the person that's in crisis with a family service issue, again, it's on them to reach out for the referral sources. We can give them the information. That doesn't need us to go to the emergency room or to act. So, I think you just got to trust your gut and your comfort level of your education.
So I know, Dr. Gist, if you're there, we've certainly been working with some folks on trying to develop additional training for clinicians as it relates to the fire service. Would you like to kind of talk a little bit about that and some of those initiatives?
Sure. We've done quite a bit of work through the Medical University of South Carolina and their online clinician training programs. Indeed, it was one of the early things we took on in the FLSI 13 project, was to try to provide training for the clinicians who are going to be serving the majority of the 1.3 million firefighters in 33,000 departments, which, as someone noted earlier in one of the sessions, probably more, only about 600 of us are big enough that we can afford to mount and maintain any kind of specialty program. So we have to depend on the folks who are out there in our communities. And these are folks who, firefighters are not their primary practice. They're working you in the middle of everybody else in the world. And in order to get them to A, have good things in their treatment kit that'll work for you, and B, understand who they're working with, we have some programs that are online available through the Center for Firefighter Behavioral Health at MUSC. That's cffbh.org if you want to explore it. Now, part of that is directed for clinicians, and there is online training they can get CEs for in cognitive processing therapy, a cognitive behavior therapy approach that works real well in this military populations. There's some stuff on assessment to help them understand how to assess the complexities of these kinds of conditions in the context of the places that you do your work. And we're right now, we have a project with the Employee Assistance Professional Association to provide a mechanism for EAP providers to build their cultural familiarity with the fire service and actually become certified in working in fire service settings. So you have a way of knowing when you're reaching out and looking for a clinician, you can either find somebody who's shown the investment to work in this setting, or take somebody who shows the interest and help them develop that knowledge and skills to work with you. That is probably going to be launched into the year, I think. The other thing that we've applied for an AFG for this year, and everybody who lives on these things, we're all waiting on bated breath for the first ones to come out, of course. But this is a really exciting project if it gets funded, as the pandemic taught us a lot about telehealth, and particularly telehealth and behavioral health settings. As we talked about the other day, it works real well for a lot of these CBT related things. It also has its limitations. You know, substance abuse, it hasn't worked as well in where you need personal contact. But it's a great way for people who don't have that quick access to a competent, especially culturally competent professional who knows about working with the fire service, to be able to be linked to somebody with whom they can work. If that comes off in about 2 years' time, we'll have a whole system to support the clinicians out there who are working with fire departments at being able to use this technique to expand their practice and expand their reach. So there's a lot going on, but at the end of the day, it still boils down to, for the majority of folks who try to get their mental health care from whatever they've got for health insurance, they get into a carve-out provider who sends them to the next available shrink who's willing to do it on a lowball bid. And that's where the problems people are talking about start to arise. We're trying to get around that by building the cadre of people who know how to work with firefighters and finding ways to put the firefighters who need them and the people who have the skill and sensitivity to work with them together.
That's good. I just posted the MUSC website to the chat room. Somebody asked about that. So good update on some of those things that are coming forward. Someone asked about stress first aid being adapted at the state level. There are a number of state training academies that have adapted stress first aid and offer it as part of their curriculum. Off of the top of my head, I don't know that there's anybody that's mandated it for all departments. But certainly there's numerous state training academies that have adapted and used it in their curriculum, and we can certainly put you in touch with different ones that have been successful at that level.
Hey, Ed, can I add one other thing in response to a question earlier about stress first aid and such support for command staff? I know locally, the Mid-America Regional Council that covers 8 counties in Missouri and Kansas that center around Kansas City, literally just last week conducted a training for command officers around the entire area. So, there's a lot of fire departments, a lot of police departments in this area, and it was specifically to develop a core group of people at the command level that you could reach out to outside your own department, but in your own area when you were looking for that kind of support. So there's probably the possibility to do that a lot of places. And I think probably, Ed, we should look with I-Chiefs about exploring that possibility jointly with, IAFC.
Good idea. Scott, anything else from your session today that came up that you didn't get a chance to get to or answer questions because of your time limit?
I think Frank asked us all the questions that were in there. There was the compensation piece. There's the chief officers. I can't think of anything off the top of my head right now. I will say that when Dr. Gist brought up the telehealth, and I'll tell you, that's surprisingly, that's been an issue for us because telehealth is, as I understand it, is being reimbursed better than inpatient. So now I'm finding that a lot of my clinicians are booked all of a sudden, like they don't have any space for us because their telehealth has booked all their appointments, or they book telehealth and they get reimbursed if you don't show up. So it's not a bad thing. It's great for the clinicians because I think they're so underpaid, but it does prove a problem for us as peers trying to find good referral sources if we're not staying on top of our referral network and making sure that they still have patients. I can't believe how many are not being able to take anybody right now.
Right. So that's a great point, Scott. And we're running into the same issue. Another issue that we're running with telehealth, and there are tremendous advantages to it as well. but clinicians get paid by scheduling appointments, and they like to have, Tuesday at 10:30 for you, and Wednesday at 8 o'clock for you, and first responders can't do that. So clinicians are not likely to take us on if we can't have a regular schedule with them, because that's how they make a living. So we're running into both those problems with telehealth. Again, tremendous advantages to it, but those are the couple of disadvantages.
Hey, I'd like to just ask Dr. West if he could unmute and just comment for a moment about how's that playing out in the military? I'm sure you guys have been dealing with it.
So we would describe our transition to telehealth as engaging 5 years of change in about 5 weeks last year. And so, what you saw at the beginning of COVID was most of the military treatment facilities, and particularly mental health, shifted largely to a telehealth model. And not only, the other key thing that went in there was not only was, synchronous video telehealth being compensated well, they extended that to be phone contacts as well. So that was a big change as a part of the public health emergency, and that has been continued. So that's been a big, we've adapted, and I think it's been a big success actually for us. If any of you have had to try to drive and park at a military treatment facility, having telehealth as an option is a great improvement.
Sense.
Hey, listen, about once a week, I watch Frank try to get on a meeting driving through New York. I get it.
Scott, another question for you. In your session, you talked about continuing education for peer support teams, but could you talk a little bit more about some of your minimum requirements for personnel when you're starting a team?
Yeah, so for our state association team and my local team, what we decided was we were going to do 70 hours of education that they had to complete before they could interact with the members as active members on the team. And a lot of that was I wanted to make sure I gave them opportunities to find topics that they were comfortable with, so they didn't have to be uncomfortable making a decision and referring to a clinician or going to the emergency room. But also because I wanted to see dedication on the members that are part of the team. So if they were able to attend all 70 hours, then they actually had to find time to be there versus the resume builders that were just looking for certifications and stuff on their resume. So we required 70 hours of education, and then we require 10 hours of professional development or continuing education every year to maintain your time on the team. And in the event that you can't get those hours, it's super lenient. We give them like 6 months to get those 10 hours in. We don't want to cut people off, but we want to keep them engaged in training. And that's pretty easy. We'll probably do one training like every 2 months. So it's easy to get the hours in. But one thing that I didn't talk about in the class in the session before was one of the things that we do with our recruits is that we do a needs assessment when they come on the job, which also guides me as the peer team leader to figure out what type of trainings I want to bring in. So, if we're coming with a recruit class of say just 30 members that are coming in, and I can do a needs assessment and see where they are, what their risk behaviors are. Then I can kind of figure out, all right, so they're coming in with no trauma, they're green and they've already got these issues that are problems. Let me build the peer team up a little bit on financial issues or substance use or risky behaviors, so that after 5 years of being on the job and exposed to critical incidents or potentially traumatic events, these don't foster. And so we tend to shift the educational piece based on what the needs of the members are. If that makes sense.
Yeah, absolutely. Perfect sense. Well, we've got about 7 more minutes left, and I don't have any questions in the box right now, so I'll just kind of go around to a couple of our presenters for any closing thoughts from today. And Frank, we'll start with you.
Yeah, when Scott was talking about education and different trends you see in a department, we try to keep up to date with that. We have about 250 peers now here in FDMY. I know it's a big department, so when they come on as a peer, they have education requirements as well, and peer training and upkeeping their education. But we do a survey, they fill out a survey and they talk about their own experience. So if they've had a suicide in their family or substance abuse in their family, or a kid with leukemia, we have a database so if we have a current situation with a family with a kid with cancer, we punch in our database and we say, here, we have 4 peers that have had this experience. And we reach out to them and we ask them if they're comfortable talking about this again with the person that's having the issue. So, keeping a database on peers and their experiences, because peers are experts in the situation. Most peers that have come to us have had a situation in their life that they can share and be helpful with. So I think it's really important to develop that database, no matter how large or small your department is, on the personal experiences the peers had. It works the other way as well. So a peer that has a child with leukemia, you may not want to send because they do not want to speak with somebody else that has that same experience. It's too raw for them. So it also gives you that knowledge to who to send and who not to send.
Dr. West, curious if you have any closing thoughts today as kind of you monitor the chat and hang out with us.
Yeah, I really appreciate you letting me be a part of this and inviting me to speak. I think one of the things that we really learned in the last year, and again, most of my work has been with health systems, not so much with fire and EMS systems, but accessibility and thinking of ways that make these services accessible, whether it be people being able to screen themselves anonymously and get some immediate feedback about how they're doing from a mental health standpoint, or just from a stress and distress standpoint, but also a way that they can then quickly connect to somebody that can get them help. So thinking about as many ways as you can make this accessible for your responders, whether that be smartphone apps or even just texting information, things like that. I think we have the potential for great success there.
Good point. Well, and thank you very much for taking the time out today to be with us. Scott, anything closing? You're the only thing standing in the way of the virtual happy hour. So
yeah, I got to go to the Speaker of the House fundraiser, so I'm going to have plenty of happy hour after this. So there was there was somebody that had asked a question earlier about vetting clinicians, are you sharing our information on how to get in contact with us for the participants if they want to get a hold of us for questions?
Yeah, we can.
Okay.
So certainly, again, and I'll reiterate for anybody that wasn't on yesterday's end of the day chat, that after the conference tomorrow, we'll be sending out a link for a survey. And then if you complete the survey, which is very important for us for our AFG funding, which again, I'll take a moment and thank FEMA AFG for funding this conference, as well as FirstNet, our gold sponsor. But when we send that survey out, then once you complete it, you'll have access to everyone who's been willing to share their presentations. And then, so Scott, we can make sure your contact information is on yours.
So I'll just quickly say that it's you have licensed clinical social workers, licensed mental health providers or counselors, PsyDs, psychiatrists. They all need to be vetted to some degree for your team, like that you'd want to refer to. So like psychiatrists, I like to make sure that they have some familiarity with the state disability pensions and the process itself so that they understand what they have to do. Our licensed clinical social workers, I like to make sure that they're able to see our members within 24 to 48 hours of them reaching out in crisis. I like them to have our members to have access to clinicians that do CBT and DBT and EMDR as therapies. So that's a loaded question that could take take a while to get into, and we don't have a lot of time. So that's why I'm happy to share my information and connect with somebody afterwards via email. I can send them stuff that I ask.
Okay, good. One last question. Somebody had, well, Scott, for you, and we'll send you this information. Somebody was interested in the assessment tools for members of your peer support team. And then somebody brought up the National Volunteer Fire Council Share the Load program and their referral list, which they debuted last year, I believe. I'm not sure about the criteria they use for their referral list, but that is certainly out there. And that's a question we get a lot about, recommendations. And I think, Frank Leto and I've had this conversation many times with people, and the very essence that, a clinician could be great for me, but not for Scott, just because of our personalities, and we could have the same issues. So I just think it's always important to have that caveat out there, that, as individuals, who feels right. So, I think some of the lists are great, but I think that's just something we got to keep in mind as well.
I love to tell everybody that you're interviewing the clinician like they're interviewing you. So don't feel bad if you're not connecting with that person, because we'll find you somebody else,
Yeah. No,
Nothing
absolutely.
I don't gel with this person. I need somebody else.
I keep trying to find a new primary care physician, and I call and ask if I can interview them, and I get told no. So I don't know what's going on with that. But anyway, well, look, that takes us to 4:30 today. It's great having everybody here. We hope you're enjoying it. We've got an exciting lineup tomorrow, talking about organizational resilience. We have 4 great chiefs tomorrow, talking about all chiefs that from departments that have experienced significant events in the last year, and talking a little bit about how they deal with that and what are some of those stresses. I think a lot of times in the fire service at the lower levels, we forget what the chief officers are dealing with. They're getting it from both directions. So we're excited about talking about that some tomorrow, and we'll look forward to wrapping everything up. So have a great evening. Thanks again for all of our presenters today. We greatly appreciate it, and we'll see you tomorrow.
Thanks, everybody.